Hi, I'm Mark Doescher, Associate Director for Community Outreach and Engagement at the Stevenson Cancer Center of the University of Oklahoma. I'm delighted to present delivery of high-quality cancer care for American Indian and Alaska Native communities. I have no disclosures or conflicts to report. My objectives are to first describe American Indian and Alaska Native communities and their unique healthcare delivery system, the Indian Health Service. Second, to highlight cancer risk factors, cancer screening rates, and cancer incidence and mortality rates in this population. And third, to concentrate on key challenges and solutions to the delivery of high-quality cancer care in American Indian and Alaska Native communities. The American Indian and Alaska Native population makes up about 2% of the total US population. Currently, about 70% of this population lives in urban counties. The dark blue counties on this map show the Indian Health Service purchased and referred care delivery counties. In other words, the Indian Health Service, or IHS, catchment area. These areas range from urban counties to larger rural counties to small, thinly populated rural counties. Note, the IHS is not a health insurance plan, but rather the IHS funds or directly provides care to roughly 2 million American Indians and Alaska Natives in 3 ways, which make up what is termed the ITU system. The I stands for IHS Direct Service Facilities. The T stands for tribally operated facilities that receive core IHS support. And the U stands for the Urban Indian Health Program that receives limited IHS support. Many of the urban facilities are located outside of the dark blue counties on this map. Next, let's examine some of the characteristics of the American Indian and Alaska Native population compared to the general US population using 2018-19 data. First, the American Indian and Alaska Native population has a high rate of poverty and a high proportion of persons who lack health insurance coverage. Second, note the high rate of excess body weight and especially the high rate of smoking in this population. Also, 30% of American Indian or Alaska Native adults report fair or poor health status. Fourth, receipt of evidence-based cancer screening is low for American Indian and Alaska Native people. Fifth, cancer incidence and mortality rates appear to be comparable to the general population rates. However, this masks the fact that the downward trend in cancer rates observed for the general population has not been occurring for the American Indian and Alaska Native population. In fact, in some IHS regions, especially Alaska, the Northern Plains, and the Southern Plains, rates of cancer incidence and mortality far exceed corresponding rates in the general population. Now let's turn to cancer care challenges and solutions. Costs, both direct and indirect, remain the largest impediment to cancer care delivery. Solutions to reduce costs include, first, increasing per capita Indian Health Service payments. The IHS was established by legislation which creates annual congressional appropriations for funding. IHS per capita payments are less than half those of the VA system. Second, American Indian and Alaska Native persons are more likely to reside in states that have not expanded Medicaid, so Medicaid expansion would help. Third, cancer treatment causes major financial hardship for many individuals, so efforts to reduce out-of-pocket costs would also be helpful. Fourth, many low-income or elderly American Indian or Alaska Native persons with cancer need assistance with transportation and housing costs when they need to travel to urban locations for treatment. Next, we need to consider workforce supply to improve cancer care delivery. We need to address the geographic and socioeconomic imbalances that characterize the US health workforce supply. Rural and underserved training tracks for medical students and other health professionals can help, as can loan repayment programs. Also, medical schools can create pathways to improve workforce supply. For example, Oklahoma State University and Cherokee Nation recently established the nation's first tribally affiliated medical school. Cancer care delivery can be improved by enhanced coordination of care. This can be accomplished by matching clinic operating hours to patient schedules, delivering cancer care services directly at ITU facilities, such as through visiting oncologists, deploying mobile vans to remote locations for cancer screening and other services. Coordination of care can be accomplished also by reimbursing telehealth visits, as has been done successfully during the recent pandemic. Also, increasing use of health information exchanges to transmit cancer care EHR data to ITU facilities could help. Cancer care can also be improved by activities to increase patient and provider awareness of state-of-the-art cancer screening and treatment recommendations. For patients, this can include public service announcements and community health education. For providers, it can include academic detailing and performance feedback. Also, helping local ITU providers gain skills such as palliative care skills could improve quality of life for patients with cancer. Cancer care for American Indian and Alaska Natives also needs to address tribal culture and tribal sovereignty. Trust takes years to build, but can be destroyed quickly. So I encourage cancer care providers to engage in genuine bidirectional conversation with tribal communities in their ITU clinical systems. Extended families and a deep respect for elders are the norm in most American Indian and Alaska Native communities. Involving family members in cancer care is an area that needs attention. Tribal sovereignty, including research data sovereignty, emanates from federal, tribal treaties and legislation. Tribal and IHS IRBs have a scope that encompasses not just individual protection, but also tribal protection. Researchers and clinicians who are involved in work to improve cancer care need to secure tribal authorizations and IRB approvals and need to adhere to data sharing agreements whenever applicable. In conclusion, ensuring that American Indian and Alaska Native patients receive the right care in the right place and at the right time requires a high degree of coordination across multiple levels of healthcare and often across multiple locations. I look forward to the question and answer session. Thank you.